I would like to introduce our chairpersons for the first session. Dr. K.M. Mahendranath, our consultant rheumatologist. He has been one of the senior most consultant rheumatologists in our country since 1984. He has also been the past national president of Indian Rheumatology Association. Recently, in the APLAR Master is the award received by Dr. K. Mahendranath on 6th September 2018. I welcome you, sir. Our next chairperson would be Dr. Chetana. Madam has done FRCP and the specialty certificate examination from the Royal College of UK. She has currently been working as a consultant rheumatologist at Aster CMI Hospital. Connective tissue diseases of autoimmune origin are always been very challenging both to diagnose as well as to manage. This year's ChanRe update will focus on merit clinical presentations of CTD with their clinical pointers towards diagnosis. Thank you.
My esteemed colleagues, it's a great pleasure to participate in 16th ChanRe update. I think it has become a routine in December, like Christmas Day. And either 16th or dates vary, but December is ChanRe's updates. And I think except one, I have participated in most of the meetings and look forward to this. And Ramnath Misra, today's main speaker of the first session, all of us in the Indian rheumatologists know him, but for the uninitiated, is one of the senior most rheumatologists in the country. He is a mentor of a generation of rheumatologists, including Chandrasekhara, Vinita Shobha, a lot of them. And he is graduated from Orissa, then it is post-graduation, then he worked in All India Institute of Medical Sciences, then he went to UK. In United Kingdom, he worked with two topmost rheumatologists. One is Dr. Carol Black, who is the world's foremost authority on Scleroderma, and Ravindra Baini in Kennedy List of Rheumatology, who was the father of the infliximab, actually. So then he returned and joined Sanjay Gandhi, developed into a world-class institution, and he has huge number of publications. He is a great teacher. He can be very witty and sarcastic even in a scientific talk sometime. But he is talking about the connective tissue disease. It's the mysterious problem, connective tissue diseases, and over last 2 decades, a lot of changes have happened due to diagnostic facilities, new imaging techniques, and all these things. I look forward for Ramnath Misra. Thank you.
Good morning, Mahendranath. Thank you very much for the kind words, and I am grateful to Chandrasekhar to take part in this update. I always knew that he is an institution by himself, but seldom has the pleasure to see the institution myself. As far as I remember, I came here the very first update he did, and he remembered me again 16 years later. It's good to see Vinita flourishing, and all the senior colleagues and the participant. My brief is when to suspect connective tissue disease and how to diagnose. Connective tissue disease generally means some disease, certain diseases. There are several clinical syndrome complex that can constitute connective tissue disease. For sort of time, I would focus on SLE, vasculitis, myositis, systemic sclerosis. It's SLE vasculitis in the typical form. They are not so difficult or challenged to diagnosis. Myositis, if it has the skin component, it is not difficult to diagnose. And systemic sclerosis is perhaps the easiest to make a diagnosis. We'll go one by one. This is a very overriding principle that connective tissue disease are generally a rare disease. So, in the context of that term, one has to exclude other commoner disease, and the signs and symptoms are persistent and there is a propensity to relapse. So, unless the signs and symptoms are persistent, one does not think of connective tissue disease. One has to exclude infection, neoplastic and metabolic condition. I would think infection has to be ruled out in order to make connective tissue disease. Any infection, leprosy, HIV, infective endocarditis, all can mimic connective tissue disease very closely. Even the diagnostic test can mimic. When to suspect lupus? In a young female, in the reproductive age group, they usually common presentation say between 20 to 40 years of age, fever, skin rash, polyarthritis, pleural or pericardial effusion, hemolytic anemia, renal abnormality or CNS. Fever not responding to all that has been done like antibiotic, anti-malarial or anti-TB. One has to suspect whether it is SLE or vasculitis. Fever is not a common presentation in Western countries, but in Indian, all the series they have fever as one of the initial manifestations of SLE. And SLE is a multi-system disease. So, you need to have 2 or more organ system manifestations to suspect the diagnosis of SLE. SLE, as the name suggests, you have a typical malar rash. When it is there, one can very confidently suspect a diagnosis of SLE. Unfortunately, it is not there in all the patients, and in dark individuals it is difficult to make out the typical malar rash. And the thing to look here is the sparing of this nasolabial furrow, which makes it a kind of a classic teaching that malar rash, which is photosensitive. There are other forms of it. You can see in the same distribution acute erythematous rash, and actually we see also patients like this who are not so acute. We do not have opportunity to actually see patients when they are early in the course of the disease. In our country they go to everyone and then they come, and by then the rashes have taken this form. These are some of the typical SLE mimics. One is acne rosacea. Its pustules and papules, and they are looking like acne. One may confuse with that. Even seborrheic dermatitis, but it involves the nasolabial fold and similar rash behind the ear. And in a child, this is called a slap cheek appearance of parvovirus B19. It is usually young child, I mean 6 years, 7 years following a viral illness. Little further on, or as time is added on to the disease, you can get annular rashes like this. These are called subacute cutaneous lupus with central clearing but peripheral erythema, and you can see also the atrophic scene with rashes like this. This is a picture of a subacute cutaneous lupus. Years ago when probably Chandrasekhar or Binita was there, I do not remember, we had a case like this, which is a discoid lupus, a chronic lupus, and there are also discoid lesions in here causing scarring alopecia. So, this is SLE can have a variety of lasses, including even blisters, or what you think as a Steven-Johnson syndrome. So, any form pemphigoid like rashes that can be seen. So, lupus, the rashes are varied, and you can, with it, a common complaint is that of loss of hair. It can be generalized, it can be localized, or it can even cause alopecia totalis. With treatment, actually the alopecia improves. Some of the hairs they come back. Unless it is a scarring alopecia, then it is unlikely to improve. In fact, she actually grew all her hair back, which is and alopecia is a very, very disturbing complaint of the patient. People might lose a limb, they are not so much bothered, but they lose a young lady to lose hair is something like the purse getting stolen. I mean, it's a very, because probably a million times in the day she has to look in the mirror to see how much of extra hair she has lost. And so is the rash, because usually these patients are young, about to get married. So, you can realize that their immediate concern is how to, that rash has to get cleared. And the physician actually takes a very indifferent attitude to rash. They are more concerned whether CNS is involved, or the kidney is involved, or the BP is high. But the patient is not bothered by that. You may, the BP might be 140, 130, but if the rash is gone, they feel much more reassured. And you can have oral ulcerations and vasculitic rash like this in the hand, palm. These are very painful also, and this signifies an internal organ involvement. This is not so good. The arthritis is generally behaves like a symmetrical polyarthritis, and many times rheumatoid arthritis patients can have polyarthritis is that, and since rheumatoid arthritis is more common than SLE, people diagnose rheumatoid arthritis. The clue, actually a good internist will see that if the urine have sediment abnormalities, then it is much more likely to have lupus. I must warn you, all that I am saying rash, arthritis, that is not there in every patient. So, patients can have cumulative or additive manifestation of this organ. So, when they have fewer organ involvement, it is difficult to diagnose. You can have, the classic case is that of a pleural effusion not responding to ATT. That is the presenting features. Any pleural effusion not responding on 3 months on ATT, you must suspect that whether it is an connective tissue disease. Patients can also have thrombocytopenia, or which have been labeled as ITP, is one of the common manifestations of lupus. ITP patients are treated with steroid, and at least a proportion of them go on to develop additional symptoms. Hemolytic anemia, if it is there, that is also, if it is positive for Coombs test, that means immune hemolytic anemia, that is there, but it is a rarer thing to initially present. And of course, lupus nephritis is the most worrying thing in a patient with lupus. They would have sediment abnormalities, proteinuria, and in the context or with the finding of rash, polyarthritis, one has to suspect SLE. In fact, your SLE diagnosis, and also SLE patients can have challenging CNS manifestations like psychosis, stroke, and if they occur in the younger age group, many of the patients are actually seen by neurologists, and nowadays they routinely do ANA. Earlier days they used to miss it out. Of course, with the advent of ANA, it has a different problem also, because ANA can be positive in many other diseases. Many patients with stroke and ANA, one is not sure whether we are talking of SLE or not. Chandrasekhar is going to deal about the immunological or the investigation. I leave it to you, but I can only say that if the antinuclear antibody test is negative, 99% you have excluded lupus. If it is positive, it may be other disease, but if it is negative, then you have lupus is unlikely. Similarly, Chandrasekhar will tell you about the anti-dsDNA antibodies. So, that's a very typical specific test for the diagnosis of lupus. The next group of disease, which is rarer than SLE, is polymyositis, and the patients present as a subacute or chronic muscle weakness. And the typical thing is that difficult to comb the hair or climb steps. This is the proximal muscle weakness, which is subacute or chronic in, again, females slightly dominant male, and again the age group is anywhere between 25 up to 65 years. So, the age group is little bit more wider than SLE. Even you can get postmenopausal females with muscle weakness. If there is a rash like this, the diagnosis of dermatomyositis is not difficult. There are not very many diseases which can have the rash as this, and this rash is supposed to be told or taught that it is a sine qua non of the disease. This rash can be mistaken, but the purpose of giving this rash or showing this rash was to say that it crosses the nasolabial furrow, and this is one of our patients with boggy eyes like this. One can think it is like a nephrotic syndrome, and if you look at the urine, actually there is no protein. This is a rash. The English described it as a violaceous rash, but we do not see that color actually in our well, these are the pictures of European individuals having the typical rash. It is a reddish purple rash, which is so very difficult to appreciate in our skin color. And you have the typical rash of a small papule on a erythematous base, which is called the Gottron's rash. Here it is a Gottron rash. This rash, if there, I do not know of any other disease that can we have a differential diagnosis. This is a slide, interesting slide to show. Where is the dermatomyositis rash over the knuckles? And where is the SLE rash? You see it is in between the knuckles, over the phalanges. This is the vasculitic rash of SLE. To someone who is not aware of it, it might be a challenge. But this is in a way a very simplistic clue that whether the rash is over the knuckles or in between the knuckles. And of course, we have, if it is dermatomyositis, there is no need of biopsy. We have very good test, autoantibodies test to make a diagnosis. This is one such autoantibody, is the anti-Jo1 antibodies, which is giving a cytoplasmic pattern. The diagnosis for polymyositis, like we have the overriding principle, we have to exclude drugs. HIV is a great mimic. Alcohol, hypothyroidism, osteomalacia. Drugs like statins are being used, so that can cause muscle enzyme elevation and muscle weakness. And the diagnosis rests on raised elevation of CK, EMG, which shows fasciculation, reduced action potential. Well, the neurologists actually do not report you that, they say myopathic pattern. I mean, our neurologist never tells what we teach. We have, you have to probe to see whether there is fasciculation or not. And the biopsy is required in the case of polymyositis, is not required for a case of dermatomyositis. Chetana says that Mahendranath introduced that she is quite good at doing muscle biopsies. We have to find out people who are good at muscle biopsy. The problem is those who are good at muscle biopsy, they don't get the patients of muscle to do muscle biopsies on them. I didn't mean to hurt you, Chetana, it's just that it's a paradox in our country. Systemic sclerosis, you don't need to be taught to make a diagnosis. It is a condition which causes thickened skin, and the patient will tell you that gradually the skin gets thickened, starts from the proximal part and over gradually coming to distal areas, and you can get pictures like this, puckering of the mouth and what is called as a salt and paper appearance. What systemic sclerosis patients presents as is actually Raynaud's. Raynaud's, I understand in southern part of India is less common, but in our part where I come from and little higher, it's a very common complaint in young females. And because Raynaud's is associated not only with systemic sclerosis, myositis and SLE, the concern is whether it is only Raynaud's or it is part of a connective tissue disease. If it is only Raynaud's, it's called as a primary Raynaud's or innocent Raynaud's. The trick that the Raynaud's is primary, Raynaud's is a triple color change of the fingers and toes if they are dipped in cold water or exposure to cold. If there are skin changes associated with it, if there is a tissue loss, then it is more likely to be part of a connective tissue disease. Raynaud's is very common in people living in temperate climates, and they are, in fact, if they are young, it's more likely they are primary. But if they have fingertip ulcers and gangrene, it's more likely due to A, systemic sclerosis, B, myositis, C, SLE, and also this newer disease, antiphospholipid antibody syndrome, can have SLE. Classic polyarthritis nodosa has been described to have SLE. Well, they have this, you can see the nail fold capillary. The normal capillary, if it is seen by a capillaroscope, is like this, but there are widened loop and micro hemorrhages. This signifies that there is probably underlying connective tissue disease. Vasculitis is a very rare disease, and therefore I am telling you this. It's a rare disease, but in the last 2 decades, because of early diagnosis and appropriate treatment, these patients or a group of some of these patients who were dying earlier now are living. It's got a very complicated classification system. Year after year, they try to revise at least the name part of it, but fundamentally they are based on the vessel size. A large vessel is aorta or its branches. There is only one disease seen in our country, it's called Takayasu. We have very seldom seen patients with giant cell arthritis or polymyalgia rheumatica, which is a very common disease in UK. Medium vessel vasculitis, there are 2 diseases, the classic polyarthritis nodosa, Kawasaki. Kawasaki disease occurs in infants and children, younger age group 2 to 3 years. Classic polyarthritis nodosa is a male predominant disease in younger age group, in the 2nd decade or 3rd decade of life. And a large group of diseases are called as ANCA associated small vessel vasculitis, and we have 3 diseases, microscopic GPA and eosinophilic granulomatous polyangiitis. It is this group of disease that a diagnosis, there has been advanced in diagnosis, and the treatment has been gratifying. Actually, patients, 99% or 95% of the patients are living up to 5 years or 10 years now. Earlier, without treatment, they used to die, 90% of them in 70 used to die within 1 year. So, it is an important disease to be diagnosed by anyone. They can present to any specialist, a ophthalmologist, a physician, a pulmonologist, a family practitioner. Best is, the best way to diagnose, if your standard treatment or whoever it is not helping that patient, refer to a rheumatologist. If the fever is not getting better, if the pleural effusion is not getting better, if the chest cavity is not getting better, if the kidney has got a rapidly progressive dysfunction, then it could be a vasculitis. Another group of small vessel vasculitis is what we were calling it as Hinox conline purpura. This is very common in children and young adults following a preceding respiratory tract. Following a respiratory tract infection, you have rashes like this. The parents will be very alarmed. Now, the disease is called as IgA vasculitis. It is just the name change, and one does not have to be very worried. The parents will be very alarmed. People have managed with only anti-inflammatory drug management. You do not even need steroid if there is no abdominal pain. And if it is like mumps, if it is presents in an adult beyond 20 years, then there is problem. Then you can have renal disease, and it has been seen that those who have persistent sediment abnormalities, a quarter of them can end up in CKD disease. This is the biopsy. The medium sized vessel vasculitis, which is rare, can present in a protean way, digital gangrene, abdominal angina, hypertension without sediment abnormalities, foot drop or wrist drop, hemorrhage, infiltrated cavities. These are rare disease. They are diagnosed by either angiography or doing a sural nerve to see for a medium sized vessel damage, intimal damage, infiltrate in the medium, vasomedium, and the small vessel vasculitis can have the rash that I showed, can have gangrene, bleed, kidney swelling. This is the ANCA associated vessel vasculitis. I have some pictures of it. These are some of the damaging damages. This is a sunken bridge. You would have heard that syphilis is a cause of nasal bridge collapse. The modern day cause is GPA. You can have gangrene like this, you can have scleromalacia, you can have cavities, or you can have mass. So, it is again a pleiotropic manifestation, and again Chandrasekhar will tell you about the immunological test. Takayasu arthritis is easy to diagnose. Most of the patients are actually diagnosed when they come for medical checkup to find that one of the pulse is missing. And the other presenting feature is young hypertension or stroke, and an angiography shows that one of the large vessel branches of the aorta is narrowed. And this is actually commoner in our country. Takayasu. I suspect you would see more likely to see Takayasu than even GPA or the classic polyarthritis nodosa. This is my last slide to give you the picture how rare the diseases are. They are very nice to talk about, and but they are in fact very rare. SLE is 1 in 10,000, your chance of picking someone SLE. Dermatomyositis is 1 in 100,000. Systemic sclerosis is 0.6 to 122 per million, and vasculitis is 39 per million. This survey is done in the British Isles. It's not done in India. We don't have a survey like this, but based on our clinic experience also, we find that SLE is more common. Then comes the hypersensitivity vasculitis, the IgA vasculitis, and then comes the dermatomyositis, scleroderma. I can give you a rough idea. We have 2,000 cases of SLE over the last 25 years. We have 500 patients of systemic sclerosis, 200 patients of dermatomyositis, and GPA number is 36. So, these numbers are important to tell you when you are seeing a case how common is the diagnosis. So, get ready to diagnose a patient of SLE tomorrow. I will stop here and take on questions.
Thanks, Ramnath, for the informative talk. We can take a couple of questions. Let the questions be very brief, focused. Don't discuss individual cases or anything. That you can do it later. Yeah, please.
I bow down to the honorable members on the dais and off the dais and honorable speaker. Now, under the connective tissue disorders, inherited connective tissue disorders also have been described. Apart from these autoimmune diseases like Ehrlich's Diamond-Marfan syndrome, Alport syndrome, etc. So, can
they also Marfan's, Ehlers-Danlos syndromes. They are also connective tissue disease which have a hereditary component to this. This connective tissue disease that I talked about is mostly the immune mediated connective tissue disease, or we can say systemic autoimmune connective tissue disease.
You know what I am trying to say, in 50s the connective tissue disorders are very limited, something like rheumatoid arthritis, maybe something like that. Now when I browse through this literature of this connective, I felt like sailing in an uncharted sea without an oar, without a sail, without a rudder among the icebergs, because a lot of syndromes have come down in this particular group. Now, when exactly these connective tissue disorders have come into the picture is the...
Actually, I agree with you. The field was like a sea or ocean. It is 1956 or 48 to be precise when the elite cell test was described by Hargreaves, and in 1956 when Holborough described the ANA test, then it was thought that it is an antibody mediated disease or antibody associated disease. Then things became clearer, and as far as the vasculitis part, I didn't deal with another anti-cardiolipin antibody disease because that would have been a little bit crunching upon my time. I would say that when we have found a marker in the blood like an autoantibodies, then things became clearer. It is 87, 86 when ANC test was discovered. Then this classification system became more focused, and I am sure that we are looking in this connective tissue disease some biomarkers that is specific for the disease, and as our knowledge has or technology has improved information, these disease groups have opened up our eyes.
There is a whisper somewhere Hippocrates and Paracelsus have reported some diseases similar to the connective tissue disorder, that is the literature available. The last question that I would like to ask, the arthritis, Honorable Speaker, you said, will it leave permanent damage to the joints or not?
Well, When the arthritis is part of the connective tissue disease, it does not leave behind usually deformity, except a group of, in SLE it's
Can we
called,
expect avascular necrosis or not?
yeah,
Can it occur because the vasculitis and possibility?
it's not so much seen in vasculitis, but it's seen in SLE who are taking steroid, you get a vascular necrosis of the hip.
Then is it necessary to do CSF analysis in neurological cases? Will there be any abnormalities?
Yes, sir, you can, one has to do CSF with a view to exclude infection. The diagnostic autoantibodies are not there in the CSF. You might see a little bit more of IgG, but the main purpose is whether an infectious cause is not there. So we look for evidence of a cryptococcal antigen in CSF because SLE patient might be having a fungal meningitis.
What about antibodies, sir?
They are not there.
We don't have anything. What about your experience about exclusively females HELP syndrome that's been reported during puerperium? I don't know what your experience about this, but
female
HELP.
That is during pregnancy, no?
Pregnancy,
postpartum
also has been reported.
I have fortunately not seen those catastrophic things. It's a close differential diagnosis of TCP and a catastrophic antiphospholipid antibody syndrome. I pray God I have not seen one.
Thank you, sir. We are very much enlightened. Very kind of you. Thank you.
Does anyone else have a question? Okay. Thank you, sir.
Okay, then thank you very much.